My name is Catherine Nodrift. I'm with the ALS Association of Texas, and I'm really excited to see you all here today. We're welcoming Dr. Gregory Holt with RQS to go through this presentation. We're really excited for him to be here. I wanted to give you a quick overview of some of the technical pieces of this Zoom platform in case this is your first time on this platform. So if you move your mouse around, if you're on a desktop device, or if you maybe give it a quick tap, if you're on a mobile device, you'll see a few options pop up. On the bottom left, you will see your mute button. That's how you can mute and unmute yourself. I will be muting everybody after I go through this, so Dr. Holt can go through his presentation and we don't have to worry about any background noise or anything. And then at the end of everything, then I'll unmute and open it up for questions. Where you may see 3 or 4 photos on the right side of your screen. To change that view, if you kind of go to the top of that bar, you're going to see a little dash, a little box, 2 boxes, and a grid. And you can change the view that you have. I recommend that you use the little box, which is called Show Small Active Speaker Video. And that will make sure that you're only seeing the person who's talking, which for the majority of this presentation will be Dr. Holt. So that's really the best view to keep this in so that you can see him and you can see everything that's on the screen. You can also, during the presentation, if you have any questions, I am going to mute everybody, but you can also put your questions in the chat box. And if you move your cursor to the bottom of your screen or look near the bottom of your screen, you'll see a little speech bubble. And in that little speech bubble, you will be able to type a message that will go to everybody. It should just lit up right now for all of you because I just typed something in there and sent it to the group. If you have a question during Dr. Holt's presentation, please feel free to put it in the chat box. I'll be monitoring this on a regular basis, and I'll be able to ask him those questions during the presentation. And then, like I said before, at the end of the presentation, I will unmute everybody and you'll be able to ask any questions that you need to. I'm going to go ahead and mute everybody for this presentation. Again, if you have any questions during the presentation, please feel free to put them in the chat box and I'll be keeping a close eye on this. We will be recording this presentation and we can send it out to you afterwards. We'll use the email address that you provided when you registered. That's all I have. Paulette, do you have anything to add before Dr. Holt gets started? Whoops, I need to unmute you first. That would help. Or you can unmute yourself, Paulette. There you go. You're good.
Okay. Okay. I just wanted to say hi to everybody, and I'm glad you were able to join us. Of course, most of us know Dr. Holt, and he and RQS, Respiratory Quality Services, is the respiratory company that most of our patients use, and all of them use it if they possibly can anyway, but they're so supportive to all of the ALS patients. And if you've had experience with them, you know how supportive they have been through all of this. And personally want to thank you, Dr. Holt, for y'all's support for our ALS patients in the community. And thank you so much for taking your time out today to talk to us about this well-needed subject. And I'll leave it up to you. Thank you.
Hey, thanks, Paulette. So if you guys can all see my screen, you know why we're here and what we're looking at. And this is the idea of elective tracheostomy. And the idea is to have a plan so it's not an emergent kind of a thing that you guys go to the hospital, respiratory distress, and you wake up with a tracheostomy. And that's not the way that it should go. So a little bit about me, that I'm from University of Florida College of Medicine. I got a doctorate in physiology studying the neural controls of breathing. I'm a respiratory therapist since 1983-84 from Louisiana State University. And right now, I'm right where I want to be. I'm at Respiratory Quality Services in Houston as the Director of Operations and Polysomnography. And what a great group. And all of the patients, all of our affiliates and the people that we work with, the respiratory therapists and all of the people that I've met are just fabulous. So when we talk about ALS, amyotrophic lateral sclerosis, and the idea is to find out exactly what's happening, what's going on when you look at it, and we talk about the nerve cells in the brain to start with. And the idea behind this is that, you know, when these cells die, it's called apoptosis. And those are the motor neurons. And the motor neurons that could be in the spinal cord or in the brain itself, when those start to die, and no one's really sure exactly how they start to die, but when they die, the axons also pull away from the muscle. And when the axons pull away from the muscle, that's when you end up with the muscle atrophy. So the muscle wasting, that occurs after maybe 30 million brain cells have already died. So when it happens, it's already going on, it's already progressed to a great degree. Now, it's not just muscle atrophy that can happen. If you look at the bottom of this slide, this frontotemporal dementia, there could be a component of this. And sometimes if you're a caregiver or a family member and you notice like laughing or crying that may or may not be appropriate, you're not sure what's going on, and you start to see some changes, some behavioral changes, you know, in your loved ones or in your patient. And that could be like a component of this FTD or frontotemporal dementia. And they try to assess all of the ALS patients for that as well, because that can mean another component to the entire disease process. And along with the muscle wasting, you could have some other motor neurons that are ending up starting to die inside the brain. And this can go to the point where, you know, you sort of lose a lot of the mental faculties that were there. So ALS is around, it's worldwide. The incidence isn't very high, but it's certainly nothing that can be considered an orphan disease any longer. And, you know, it can be a disease of exclusion. We try to figure out if it's something else, you know, something that is not as progressive in nature that this one might be. When we look at it, it's like non-invasive ventilation and some of the other things that come up, some of the things that we notice. So we always look at respiratory function. And the idea is that most of the time in ALS, there's a muscle wasting, and then it starts to like have an effect over the breathing musculature. So you'll end up with shortness of breath. And a lot of times that's noticed mostly at night, where there's already like going to be a decrease in ventilation, but it ends up being a hypoventilation, to where the ventilation is actually reduced from daytime levels, and it could be reduced more so in ALS. You might wake up with a headache in the morning, generally self-limiting, to where it lasts maybe 10 minutes and goes away on its own without treatment. You could be sleepy during the day. You could have nightmares, memory problems, and orthopnea is one of the biggest things to look for. If you have shortness of breath, or you feel like you can't breathe when you're laying flat on your back, it's called orthopnea. And that's the idea that you should have non-invasive ventilation. You should have face mask, and you should have like one of these ventilator type devices. And CPAP is not it. You know, we're all interested in what's going on with the virus right now, and they're talking about using CPAP machines in lieu of ventilation, and it does not work in ALS at all. So if you had a component of sleep apnea before ALS, CPAP has got to be switched out for something else, because this continuous positive airway pressure implies that you can breathe spontaneously on your own. And eventually you lose that ability to initiate a breath, you know, on your own, and that's where CPAP starts to fail, BiPAP as well. So when we look at this, dyspnea means shortness of breath. If daytime dyspnea is happening, if any of these symptoms are happening at night, generally within 4 to 6 months, you'll start to develop daytime symptoms. And what the research shows is that the earlier you initiate non-invasive ventilation, the longer the survival times are. You know, and that's why we're looking at tracheostomy today. We're looking at like survival times then to see what the quality of life could be with a tracheostomy, decide to change or not. So these two measures at the bottom here, objective measures of ventilatory dysfunction, it's two numbers that worldwide we've looked at to say that they're one of the biggest indicators for the need of non-invasive ventilation. Forced vital capacity, the FVC, less than 50% are predicted. The forced vital capacity is taking a deep breath in and blowing out as hard and as fast as you can. And when you hear somebody go, blow, 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 that's what they're doing. They're looking to see how much air you can blow out and how fast you could get it out. And so they built up these table of predicted normal values. And if it's less than half of what it should be, then they say that there's some significant ventilatory dysfunction going on. MIP, maximal inspiratory pressure. You guys have all done this, and you've seen it done. It's where you put this mouthpiece inside your mouth. Your nose has usually got some clips on it, and you suck in as hard as you can. And if you start to where you can't pull as hard as you used to be able to, we always look at trended values. If it's like minus 60 or higher than that, if you look at a number line, minus 60s on one end, and then it would go to minus 50, minus 40, minus 30, that means that there's more respiratory muscle weakness. The diaphragm, accessory muscles of inspiration are starting to lose their capabilities. So there's a point where you can't generate that kind of a force. And if you can generate normally minus 100, minus 120 centimeters of water pressure, we're looking at that to start to reduce, and we follow those over time. It can't be like one set number. It's usually followed over time to see how fast ALS might be progressing. These are called disability milestones. The disability milestones are things that are happening over time and things that you might need over time. So you kind of take a look and follow your own progress. You start off with like a walker, rollator, things like that. Then you move to a manual wheelchair, power wheelchair. Then you're into like a peg tube, enteral nutrition. You're looking at non-invasive ventilation. You're looking at a face mask with a Trilogy device. Then you're looking at invasive ventilation or a tracheostomy tube, and still with a Trilogy type ventilator. Speech generating devices, Toby devices, anything else like that is part of the assistance that you could get, with ALS, all the way through hospice. So they've got an idea of the things that you move through, that people are trending, that maybe no one's talking to you about, but this is what everybody is looking at to sort of gauge where you are. Now, the thing is that if you look at this, it goes 1, 2, 3, 4, 5, 6, 7, 8. All right. But some of the research, remember that if you take non-invasive ventilation and you move it up higher in the list to where it is right around number 2 to number 3, they've shown that survivability is increased when you get on to that face mask and a Trilogy device earlier. And that's when your FVC is like 65% to 80% are predicted. So some of the data that's back from like 2003 shows that early intervention is better. And I think it is, because there's not so much of a strain on your respiratory muscles, and it like gets you compliant and used to using the mask to where you're on it. You're not having to fight it when your muscles are already weak. So it makes sense to me. Now, the cost associated with all of these, we won't spend a lot of time on here, but you can tell that, the kind of costs that go along with this increases as those disability milestones are reached. So for one thing, you guys don't want to have to burden yourself with the cost, but the cost of tracheostomy versus non-invasive ventilation is something that everybody has to consider. Those are the things that you have to talk about. You talk about like your quality of life. You have to talk about the finances that you have available, the type of insurance plans you have. You have to have all of those very, very difficult conversations at the onset. At the onset of diagnosis, it's like nobody wants to have like a plan in place, but once you wrap your head around the idea that this isn't going away, then you talk about everything that makes you feel okay about down the road. And the best thing about that, change your mind. You can get all the way down to the end. It's like, I'm not doing that. And then you can change your mind, you can figure it out and do it again. What you don't want to have happen is that have that frontotemporal dementia start to like roll over you to where you can't make that choice. You can't communicate any longer with what your choice is going to be. You have to have a plan in place, and you can change that plan as long as you have the mental abilities and the faculties about you to make those kind of decisions. But you can always change your mind, but you don't want to get stuck to where you have that sort of a locked in syndrome where you can't say what you want to say. So I think the big point right here is to start talking about these kind of things. Everybody talk with the ALS Association members, talk with social worker, your physicians, nurses, respiratory therapists, just ask questions. And, you know, and sometimes they want to keep pushing that kind of a difficult question to somebody else, your doctor, you know, your social worker, but it doesn't hurt to ask. So this is non-invasive ventilation therapy. This is the mask, because the idea here about elective tracheostomy is that chances are you're already on a face mask. So how do we get you used to it? We look at everything that's going on with it and then try to figure out if we've optimized everything possible with non-invasive ventilation. We want you to be able to use this, use the face mask just as long as we can, because that's one of the things that you have to consider about tracheostomy is whether or not it's no longer supportive of what you need. So we look at leakage, the mask issues, could be soreness. The nasal bridge is always a big problem here. You can't have to where you're getting like a lesion starting on the nasal bridge. Face mask will leak over here. They can leak underneath your mouth, but all of these companies, Respironics, ResMed, Fisher and Paykel, everybody makes a triangle a different way, different materials, different facial types. So try different ones if at all possible and find the right one that fits with you. So once you get past all of these things and the problems and you have support of the respiratory therapist in this type of an issue is a must-have, because they're the ones that are going to be out there trying to refit that mask. They'll try to make adjustments on it, and all these masks, if they're on too tight or too loose, they're going to leak. If you roll over onto your side and that pillow pushes the side of a full face mask, all masks, they'll all start leaking. So that's just the thing. You'll be repositioning that mask during the night, no doubt about it. Happens to me. I put myself on a CPAP machine 15 years ago, never looked back. I sleep a whole lot better with it on. Think of yourself, even though you have ALS, you're using the same kind of mask that those other patients need to use. And there's probably about 15 million of those guys that need to use that kind of a mask. So if you have problems with sleeping, it's time to start thinking about non-invasive ventilation earlier on. And it's not CPAP, like I said, it'll be something called BiPAP AVAPs. This assured volume, average pressure support. Well, they're looking at it to give you a set volume coming in. So they average the tidal volume and it's assured by pressure support. And the BiPAP means bi-level positive airway pressure. When you breathe in, it goes up to a certain pressure. Exhale, it drops to a certain pressure. So we try to use this BiPAP AVAPs mode initially. And if it starts to where anything else is going on, we may be switching you over to a Trilogy device, and the sooner the better on that. Because if you get short of breath, you're going to want that battery backup that a BiPAP AVAPs machine cannot support. It doesn't have battery backup that is plugged into the machine to give you 8 hours if the power fails at the house. This perseverance, keep trying to use it, get to where you've got it. Compliance is great. Compliance and benefit are some of the things that we always look for. And then see how you're feeling. The idea is that if you sleep better at night, you feel better during the day. If you're breathing better during the night and breathing better during the day, it's a big thing. So non-invasive ventilation could be either this BiPAP AVAPs device, or it could be a Trilogy device. But remember, there's some things about the Trilogy that are just absolutely far and above and beyond what a BiPAP AVAPs device can do. So if you're short of breath during the day, you should have been on a Trilogy probably about 4 months earlier. So don't wait till you get to that kind of ventilation that you need. But you'll feel better. The idea is quality of life. It's something that we should all be shooting for. Symptom support. That's what we're looking at as far as respiratory symptoms. We've got non-invasive ventilation, invasive ventilation. Once you're doing that well, you're not going to feel short of breath all the time, and that's something that we try to avoid. You try to stay ahead of it, be proactive to it. Instead of saying, I'm short of breath now when I do some things, I think I'll talk to my pulmonologist when I see him again in 3 months. You don't have a lot of time to wait. You can't wait for those kind of appointments to come around. So when you start to see your numbers are dropping pulmonary function, we're all looking and we're all trying to help you guys make decisions of like what could be going on. So respiratory support is a big part. Pharmacological treatments, is another part that helps. There is no cure, but that helps. Riluzol's been around for a while. It's been shown to help. Radicava is the same way, has been shown to help. But, you know, all of these, it's like help, how much help? Sometimes not so much. But it's what we've got. Some new things that are coming out, phenylbutyrate, this taurodeoxycholic acid, it's a bile salt. They use combination drug therapy, which is like a nice thing going these days. And both of these drugs have been tried individually. Now combination therapy, they've shown some effectiveness with that. So that's something new, relatively new, that's coming around. Like drug like Radicava and Davarone, they were trying 15 years ago. And it wasn't really that effective back then, but they rolled it back out and given it another shot and see how they do. But here's the big thing, and this is the thing that research has shown a lot of effectiveness, improvement of quality of life, improving survivability, is interdisciplinary teams, where guys like the ALS Association, medicine, nursing, physical therapy, occupational therapy, speech language pathology, the dietitians, social work, respiratory therapists, everybody is there. Everybody is working to, like, with this one problem, to try to make sure that you get everything that you need and get those questions answered and the kind of support that you're after. So to be a part of an interdisciplinary team is a big, big thing. So let's all like try to make sure that we're involved with those guys. Here's a question. I'm a Japanese group working with ALS. The idea is like, you know, decision regarding your life. You have a chance at long-term survival after tracheostomy and invasive ventilation for several years, but need to consider whether you would value life supported by mechanical ventilation with extremely limited physical ability and loss of mobility. That's what they asked their patients in Japan. Now, if they ask this kind of a question, this is like from their research article, they would ask this question and then help the patients decide tracheostomy or not. So 30% of ALS patients in Japan have a tracheostomy. That's opposed to about 10% in the US, maybe less, and definitely less in some of the other countries. But the Japanese support tracheostomy and invasive ventilation. Most of those patients are in the hospital and cared for, and the government foots all the bills for like tracheostomy. So that's not been a concern in Japan. It's like if you would like tracheostomy and invasive ventilation with ALS, then it's on. The downside about tracheostomy and ventilator when you're in Japan is that you can't decide to come off of it. You know, you can't decide that, well, that's enough for me. You know, I'd rather let nature take its course and come off of this. No, they won't let you do that. So that's an issue there too, but they're looking over that right now to try to figure out, are we being cruel by like increasing the duration of suffering in this population of patients? So it's a cultural difference that they have as opposed to the US, and we'll come back to that. So very nice graph here. So somebody that chooses to, a group that chooses to not accept any kind of face mask ventilation, home mechanical ventilation, the guys on non-invasive ventilation with a face mask, and the people with ALS that decide to go tracheostomy and invasive ventilation. So when you look at the 50% survival line here moving across, you can see that, you know, by the time that you reach 30 months, half of those guys are surviving. By the time you reach about 40, 45 months, the guys on non-invasive ventilations, half of those guys are surviving. And then way out here, the 50% survival curve is up past, you know, like around 80 months or so. So definitely, definitely using tracheostomy and invasive ventilation extends survivability, you know, with the ALS population. So it's a big thing. And this is that same group that posed that question. So this is research from 2014. So in the research world, not so very long ago. When you're looking at this, it's like, who gets the tracheostomy? How do you choose? When do you decide that it's an elective thing to do? Is that if you're less than 65 years of age, those are the guys that are deciding more so than the patients with an advanced stage. that yes, that I think that I'll go with tracheostomy, and especially if you're married. So that's a big point too, is that if you have a spouse and you've talked about it, discussed it, you looked over finances and everything, generally those guys are choosing an elective tracheostomy. Now, tracheostomy is the actual stoma. The tracheotomy is the procedure to put the stoma in place. So we use the terms tracheotomy, tracheostomy sort of interchangeably, but the idea is that, you know, for the most part, tracheostomy is what we're looking at. Mostly males, but not such a big ratio of a difference. It's between it's like 1.6 times over females, unless the female is alone without a spouse, so it could be increased in that population. Most that have experience with non-invasive ventilation, they know what a trilogy is about. They know what an astral is about. They know about mechanical ventilation, and they're okay with it. You know, they're experienced with it. Now, on loss of motor function, so if you have like upper limb functional lost, that's not so bad. Those guys are going to tracheostomy, and you see these numbers drop when you get to bulbar symptoms. And the problem with this is it's almost like there's not so much of an understanding of non-invasive ventilation when you're looking at ALS patients with bulbar symptoms. And that's because they lose a lot of the muscle tone up here, and they have other problems with secretions. And sometimes it's not easy to get used to non-invasive ventilation with bulbar symptoms in ALS. So they choose that, you know, that maybe I don't want to go that route and have a tracheostomy. But if you work with an experienced respiratory therapist, non-invasive ventilation, and you have bulbar symptoms, they adjust things like the pressure, the inspiratory time, the flow rates. They change all that to make it easier to get used to it. And then if you have secretion issues that it's not being helped by medications or any other procedures, sometimes a tracheostomy is the way to relieve all of those problems with secretion excess and protect the airway with the tracheostomy. So it's something to consider. Don't say that, oh, I saw this slide from Dr. Holt that says bulbar symptom ALS patients don't really go for tracheostomies. And it should not be the case. I think it's a bigger case in this study because they didn't have the right kind of support for non-invasive ventilation. Now, by country, keep in mind that the US is about 10%. This is a little bit low on the estimate at 1.4%. It's probably higher than that. In Japan, up to 30%. And then all of the European countries, it's pretty decreased. And they don't push it. It's not a social thing, but that's why we have an increase in Japan. Socialized medicine, all costs with non-invasive ventilation and tracheostomy and invasive ventilation. And here in the US, this happened just a few years ago. Medicare cut reimbursement by 1/3, and there's more cuts coming out right now for like being on home mechanical ventilation. And with all the talk with COVID-19 and ventilator shortages, they're probably going to back off on some of that. I would hope that they would realize how important home mechanical ventilation is. So there's changes that are happening all the time, and maybe some of these changes in the right direction for ALS and mechanical ventilation will stick. Let's all hope, but we might ask for everybody's help at some point when it comes down to it. So having a tracheostomy and mechanical ventilation, invasive ventilation, highest outpatient coverage costs. And that's just the way it is. If you're like a patient living at home with a tracheostomy and you're on a ventilator, it's fairly costly. Some of the things that predict longevity after tracheostomy and invasive ventilation: younger age, having a PEG tube in place for enteral nutrition, nutritional support, gender, sometimes the males. Preservation of motor function is still a big issue. If you have some motor function, that it's not such a problem to like decide on tracheostomy. The site of the symptom onset. Is it arms, legs? Is it bulbar onset? And try to figure out what could be some of the issues that are happening to help people decide whether or not you want to go with a tracheostomy. And this home versus hospital. Big thing on quality of life, all the research articles show that if you have a tracheostomy and you're on invasive ventilation, living at home is a better predictor of a higher quality of life than being in the hospital. So they found that people are happier if they have ALS, tracheostomy, and they're living at home. They feel like their quality of life is up. These are the two biggest things for predictors: younger age and the idea that you can go home and with the tracheostomy and invasive ventilation, biggest things to predict longevity. So we're looking at quality of life, you're looking at family support, financial resources. If everything is coming across and it's like, sounds like, you know, I've covered all my bases, make sure that you're talking to everyone, family members, loved ones, spouse, everybody about this. So the individual reasoning to get a tracheostomy is if the disease is like progressing really fast, because when you're a caregiver, when you're in healthcare and a provider, when we say somebody is like rapidly progressing or slowly progressing with ALS, and it's not all the same. And that's why, you know, there's some thinking out there in the research world that it's not the same disease with every single patient there is. And right now, you guys, it's like, well, it's either sporadic form or it's the familial form to where it's genetic. That's the only two, right? So, and not always the case, because even if it's the familial form, there are some ideas that there's like 100 or 200 differences among the types of problems going on with the familial form. So it's not always the same. And that's why we have different rates of progression. When you have that symptom of shortness of breath, increased symptom of dyspnea, that shortness of breath will get you to decide pretty fast whether or not ventilation is for you, to use non-invasive ventilation, to use a tracheostomy and invasive ventilation. So you get the idea whenever you get short of breath. Now, some of the ideas, it's like, well, if I get on tracheostomy and I have increased survivability, and you do, maybe there's a cure right around the corner. And that's always been our hope through the association for everyone that's worked in ALS, that it could be right around the corner. And it's not. It's not right around the corner. Everybody hopes there is. And I've been to some of the really, really nice meetings from researchers that are out on the front lines. They're still trying to figure out exactly what causes it. There goes a light. That's why I have a lamp. Wave my arms, get the light back on. So maybe there is, maybe there isn't, but you know, there's always that hope that you are right there. So if you go with a tracheostomy, always think that, you know, this could be something, because there's nothing wrong with hoping that somebody comes up with a cure. Drug therapies, combination drug therapies. And when I look online, I look at the biologics to see if there's something new coming out with those guys, and everybody is working for it. So, you know, it's always good to believe that something good can happen. Whether or not that you accept that ALS always ends one way. I mean, that's the tough part about it. And that's where you start asking these questions. It's like, I understand what's happening. I understand that respiratory failure could be the end of things. But to understand it, it's like, this is what I'm willing to accept for myself on how I want to live. Am I going to like live and die on my own terms? Or is it going to be like another ER visit and they're going to do things to me that I don't want them to do? So these conversations have with everybody that's around you, especially those closest to you. You've got to talk about what you think and how far you're willing to go. So you want to maintain a certain level of living. That's it. So it's like, sometimes there is like a lot of things that you can do. And you talk about Dr. Stephen Hawking with ALS that had one of those kind of early on Toby devices. He was writing novels still, you know, just with eye blinks and things like that. So there's a lot of capabilities associated with it. And this guy was from England, of course, but the only voice that he had on his device was an American accent. And he decided he just didn't want to change to an English accent. And even when they offered it to him, he was like, no, got kind of used to that same kind of accent. So he stuck with it. So when you're out there and you're talking to speech language, you know, speech path, and ask them about things, well, get ready to start things like voice banking early. You don't want to get to a point where you can't voice bank, or you depend on maybe a family member, or like Stephen Hawking, you just get that accent that you want. So if it's ALS, you can talk to them about voice banking. You talk to them about a Toby device early on. That, you know, it's what I want to do. And you can control things all over the place, like your television. Alexa is coming up and is big. You can control doors opening, lighting, all of that. So, and those things are happening all the time. There are new things that will still give you that kind of like control and independence that you can maintain for a long time. And when you think of your spouse, it's like, it's a meaning for life, socioeconomic support, caregiver. It's a lot of important things that go along with being married, and this is one of them. And this is one of them that you want to talk to about, especially about how much, the support that they are going to be able to do. Because when you jump into it, you can always change your mind, but you're always looking for that kind of help that's supposed to come from your loved ones, and that's a big deal. So the significant things: spouse, age, non-invasive ventilation use, financial status, those are all things to decide. If you had to walk away from anything, take a look at these 4 things here and then start asking the questions along with that idea, your quality of life and what you're willing to accept when you have a tracheostomy and go with invasive ventilation. These are the things that I consider as like where I draw the line. This is where I'm not going any further than this for ventilatory support. And you're asking yourselves the question, I'm right there, I'm on non-invasive ventilation. Is this the idea? Is this the end of my life as like respiratory failure? And the idea is that respiratory failure is the thing that ALS patients will suffer from. So putting on a face mask like 15 million Americans are on for sleep apnea is not the end. I've been wearing one for a long time. A lot of people wear those kind of face masks, and we don't feel like we're tied to a machine. We feel like it helps me sleep, and I feel better during the day. So respiratory failure is not it. So, it can't be a spot where you draw the line, but people do with ALS. It's like, I'm not going on a device. But is the ventilatory support the beginning of a new life with ALS? That should be an easy enough transition too. It's like a face mask, I'm on it. And then we see like, how long am I on it? What kind of pressures do I have? What kind of things do I run into that makes my life more difficult? Is there a lot of problems with mask discomfort, leaks all through my mask, having to have this thing around me all the time? And it goes along with ALS, but you can put a trilogy on the back of a power wheelchair and take it with you. What are my levels of acceptance? Something that everyone decides for themselves, Are you okay with that progressive loss of muscle control, like in general? It's like, well, it is happening, but how much of a loss? By the time you're on tracheostomy, it may be that you're not moving too much. It's like, is that where you draw the line? But these are all the conversations that you have. These are the things that you go over in your own mind before you have the conversations with your family and spouse. But have that idea that, it's not a decision that you make lightly, that you're considering everybody else around you, and you're considering the things that will go along with it as things progress. But this last one, cannot stress this last part enough. Do I have my wishes understood for continued care if I'm affected by progressive loss of mental capacity, frontotemporal dementia? So have a plan in place. If you start seeing, that's happening to you, that, that it's like, there's nothing wrong with an emotional outburst here and there, or just have a feeling, but sometimes there's such a progressive loss in what you can and can't do or think about and make communicate. When you're starting to lose that, then you've got to have that plan in place, because, to have that idea that you're on a trach and ventilator and you could be supported for a long, long time, but you're locked in with no ability to communicate, and you have no idea what's going on. That is not the right spot to be in for the patient, for the family, and for anybody. And it does happen. It does happen a lot. That we've seen that happen in different disease states too. So that's gone on. It's positive side, and I like this one. This is like, all right. So what are we looking at here? It prolongs survival, no doubt about it. You will live longer if you have a tracheostomy and you go with mechanical ventilation, and that is a bonus. If you didn't say all of those things that you wanted to say, if you were like to do some things, and we have people on non-invasive ventilation and guys with a tracheostomy that are still doing some things, that are still like in a wheelchair, power wheelchair, and still going to like they're going to rock shows. We took a patient with us to the Heart concert like about 5 months ago. So Keith Sanborn from RQS was like, hey, we're going to go pick somebody up and we're going to take him to a show. Do you want to go? It's like, all right. So there's still some things that you can do. People go on cruises. People go hunting with their Trilogy machine and a face mask. So we have pictures of patients, ALS patients, that have bagged a deer, you know, that are still out there. So you can have tracheostomy with mechanical ventilation. Your quality of life can be good, you know, can be up there. And so most of these guys, and we're looking at 90% by the literature that says that they're happy with the decision they made, that it's okay, that, you know, they're doing all right with the tracheostomy. And now only half of the caregivers said that they would choose it for themselves. So that says something too in itself. It says that, you know, that maybe the spouse, maybe the family members, or if it's like a hired caregiver, that they've said, no, I could not go that way. You know, it's like, I would not choose that. It's like, well, you don't know until you get there. So it doesn't matter what those guys say. It's like, you know, it's what you believe as the patient and what you want to do. So consider all of those points to say that I would or I wouldn't. So keep in mind too, this last point, quality of life is higher with the tracheostomy and mechanical ventilation if you're at home. If you're at home compared to a long-term acute care kind of facility, ventilator facility, SNF, skilled nursing facility, if you're at any of those kind of places, being at home with the tracheostomy and mechanical ventilation, all of those guys report a higher quality of life when they're there. Complications, you should know that there's always some issues with anything that you choose. Bleeding, of course, especially early on after you've just gotten a tracheostomy. If you pull on that tube, bleeding could happen. It could start causing some issues. Blockages can happen anywhere through the entire time that you have a tracheostomy. So you're trained, caregivers are trained to like how to suction, how to clear blockages, how to replace intercannulas. People are trained on how to replace the entire trach tube. So there's some things that are going on that you'll get better with it over time. But these pneumo something or others, pneumothorax, very dangerous, airspace like around the outside of your lungs. Big issues there. Pneumomediastinum, air around that sac of the heart, you know, and the inside parts of the thorax, the chest. Subcutaneous emphysema, it's when air gets inside underneath the skin. It's like when you push on it, it's like crunching down on Rice Krispies under the skin, but it goes away and it's not dangerous. And bronchospasm is just those coughing fits that you have. It happens all the way through the, you know, the entire course of care with tracheostomy. So you could lose the trach tube is like a, you know, sort of a middle of the road timing if you have tracheostomy. An infection could be up. Oh, of course, that you've bypassed all the normal protection and you've opened up that sterile field inside your lungs. So infection could always be a problem, and it will always be a problem. These late complications of a tracheostomy, tracheoesophageal fistula is just an erosion of the tissue linings between the trachea and the esophagus, your tube that goes from your mouth to your stomach. If that happens, you can end up like coughing and choking on things whenever you're trying to swallow anything, and it's something that they would repair surgically. Tracheomalacia is just a thinning of the tracheal wall. It's from the tube and the cuff rubbing against the inside of the wall of the trachea. You really have to be careful about the cuff pressures when you have a tracheostomy tube, and that's something that we teach as well. How to use less, you know, minimal amounts of air and pressure inside that cuff so it doesn't put too much pressure inside the trachea. And surgery related to tracheal damage always comes up. If the trachea has these issues, sometimes you have to have like surgery to correct those problems. Now, these are important here. It shows you some like a timing. When you look at the timing of this, 1993, 2012, 2011, look at these survival rates back in 1993. So, you know, it wasn't like ancient times, the old days, but here, like 52 patients with ALS, 48 died from tracheostomy tube complications within 5 years. 13 died within the first month, 1993. Bad time to have ALS and decide on tracheostomy. And then when we just move, you know, you know, a couple of decade later, you're looking at like survival rates, 47 versus 31 months on non-invasive ventilation, just the face mask. So right now, having a tracheostomy, you know, 2012, there was improved survivability with a tracheostomy right there. So that was nice. And this is patients less than 60 years of age. So we're looking at survival rates that are like close to lung transplantation, 80% at 1 year right now. That's wonderful right now. So you can't think of tracheostomy as being completely dangerous where the survivability is just gonna drop like a stone. I'm not gonna do it at all. Don't think that way either. You know, when you got the right people behind you, the right respiratory therapists, the right equipment, and the right training and education, you know, you're in a good direction. So when I said that you can decide at any point, it's like, I don't want to do it anymore. You can do this with a tracheostomy, mechanical ventilation. You could do this with a face mask and home mechanical ventilation. It's like, if you don't feel like you want to do it anymore, it's fine. It's ethically the right thing to do if you make that decision that I'm going to take myself off of ventilation and I'm going to let nature take its course. You know, it's like this, you know, you choose the timing, you choose how it's going to happen, you choose who you want to be around, and, you know, then it's like the entire thing of death with dignity with your family, your wife, your husband with you, children, just all of those people that you want to be around you. So when these have already decided upon is what you will do and what you won't do. So we'll use sedation to cover the symptoms of dyspnea and anxiety. So if you're short of breath, they're going to use opiates or one of the sedation types of drugs, the benzodiazepines or the Valium class of drugs, to just reduce the anxiety associated with it. And that's important, you know, that you use enough medications to relieve that symptom of shortness of breath. And you remove ventilation, slowly turning things down to you're breathing on your own. And then they try to take the mask off, or they take, you know, remove you from the tracheostomy, like a line, the ventilator circuit. And that's still more sedation to alleviate the symptoms and no further. You're not trying to snow somebody or send them out with a drug. It's not the point. But if the use of those sedating medications also causes respiratory suppression, it's okay, and it accomplishes the goal of easing suffering. So it's like a double effect. So you're relieving the anxiety, you're relieving the shortness of breath, and then you're relieving the suffering associated with that fear of dying. So the right amount of drugs, you have to have the right people there too that are with you on this whole thing. And it is never called assisted suicide. That is not the point on this. This is to remove mechanical ventilation and to let nature take its course. That's the whole idea behind this. And you control that. You control that as long as the advanced directive is in place and that you are, you know, you have the mental faculties to back you up, that this is your decision that you're making now. So, can't think of tracheostomy and mechanical ventilation is like the end of it all. You know, that's not the point at all. So it's not the beginning of the end. You're looking at the final things that are going on. Survivability is prolonged when you choose tracheostomy and home mechanical ventilation. It's something to consider. And if you know enough about tracheostomy and mechanical ventilation, you'll have those resources and you want to live, those are the things that you would think about, you know, when you make those decisions that go along with an advanced directive. Is that you have to know enough about it. You have to know what's going on with it, and then you decide. You know, you can't go into it blindly. And if you're on like non-invasive ventilation or not on it, and you go to the emergency room in ALS with shortness of breath, respiratory failure, you could wake up with a tracheostomy, and it was not your decision. You know, you will just wake up with it. And that's something we try to avoid. It's like you never want to have these things like flung upon you emergently. Have an idea of what you want and have that advanced directive in place is the kind of thing that I'm trying to get across. It's like, it's not a pro or con or what do you believe or what I would do for myself. It's the idea of like know enough about everything and then you get to decide. So technology, education, compassionate care is supported throughout the course of the disease. Big point about it. that's exactly where I want you to end up with, is like after a talk like this, that you know what you need to think about, and you know those kind of discussions that you need to have. So that's how to reach me at the bottom. And this is us. And my wife, Leah. This is Liam Stripling, Will Stripling, one of the respiratory therapists. You probably know him. Looks just like Will. Precy, right here. My two kids. These are Afia's kids on this side. Morna works the front office. Dr. John Nielsen Stewart, you probably met him at some point. I know everybody here except for the dog. I don't know the dog, but that's what's going on. So you guys let me know if you guys have any questions.
Thank you so much, Dr. Holt. I'm going to go ahead and unmute everyone. If you have any questions, please feel free to either put them in the chat or just go ahead and speak up. Everyone's unmuted right now. And we will send this presentation out afterwards. And Raquel, I just saw your note. What was your email address? We'll send out Dr. Holt's contact information and a recording of this presentation out afterwards to everybody.
Do you have a question? Do you have a question?
I have a question. Go ahead.
Yes, ma'am.
I have a question. Is the trach less successful for people over 70?
Well, they just see that, you know, their survivability isn't in like terms of years, because old age is you know, on you as well.
Old age.
Yeah. So it's one of those things that's like, oh, then there's that. But no, it shouldn't be like, you know, something to make you decide against it as well. But it is a consideration, you know. It's like, all right, so when you look at those curves, it means more to like who decides on a trach or not, depending on their age. And yes, that's what the literature shows. So the idea that everything I try to present here is some of the findings from research articles of like who chooses it, who doesn't choose it. But you know, we have patients, and our numbers for our patients at RQS are similar to the national average. So, you know, about 10% of our patients choose tracheostomy. So we have a lot of respiratory therapists that also have like got a lot of experience with people with tracheostomies, and a good number of them are like over 70 years of age.
How much would it cost? Oh, I'm sorry. If you're on Medicare, what would the cost be?
The cost, I can't tell you, you know, the cost exactly of like the procedure, the supplies, but I know that, you know, because of the everything that goes along with having tracheostomy and mechanical ventilation, the costs are higher. But as far as out-of-pocket expenses, that part I can't speak about. You know, I can't tell you about that. I know it's different for everybody.
Dr. Holt, we have a comment in the chat box. Can you comment on COVID-19 in relation to tracheostomy, i.e. acquiring the virus may expedite the decision for people with ALS?
Expedite what kind of decision?
A decision on tracheostomy.
Oh, well, don't let the virus throw you off, you know. For right now, it's not a good time to change anything. It's not a good time to go to the hospital. It's not a good time to like go out to buy food even, you know. It's something that you have to do. If you can't get someone to drop it off on your front doorstep that you can disinfect on the way into your house, I would hold off on any kind of like, you know, major decisions for the next, you know, few months anyways, until we get past this. And we will get past all of this. But for right now, you saw the changes that RQS was making, that we're doing FaceTime. You know, we're coming over if we need to, but when we come over, you know that we'll be wearing gloves. You know that we'll have a mask on, and it's for protection of the patient, protection of the therapist, because everybody is doing different things. But yeah, it shouldn't be the thing to think about like today. I want, you know, do it today. But you know.
Yeah, this is Dutch. Just a clarifying question. So if you get the virus and you end up in the hospital, what I meant was you may have to make a decision about whether to go to get a tracheostomy or not, where you might not have to make that choice for some time.
Well, I think if it was like respiratory support because of the virus, that they would do endotracheal tube intubation for everybody that's got, you know, a viral infection like this. And then you have to get them through that respiratory illness, which is much more dangerous than, you know, the predicted time of survival for ALS, because this one results in adult respiratory distress syndrome, where all of these like mediators of inflammation are cut loose inside your lung and causing fluid to shift around your little air sacs, the alveoli, and into the alveoli, and your lungs are filling up with fluid that makes it difficult to like get oxygen into your bloodstream. So you'll be intubated if it goes that far. And, you know, if they get you past the disease, which is tougher when you're, you know, you're over 70, 80 years of age, it's got a higher mortality rate associated with that age. But they would still try mechanical ventilation with you and still try to get you past the disease, the viral infection. And there's a combination of drugs that they use. I mean, you know, it's something to consider. It's like they know what the drugs they can use. There's some antivirals that are in place. If they can, ARDS by itself carries a high mortality rate all by itself. But now, you know, it's like a lot of things are happening, but they have ramped up the kind of things to do, you know, for this virus. So
Thank you.
You bet.
I believe James Tobin has a question.
Yeah, I think we have our salt and pepper shaker on our table instead of
I was watching that. Lunch is served.
I'm going to ask a question on the maintenance of somebody with a trach. I've heard rumors that they have to be suctioned every hour and a half, so you have to have someone with them all night, a caregiver. Is that the case?
Oh, you have to have somebody with a trach patient 24/7. Yes, ma'am. Now, you have to suction them every hour and a half? No. You know, it's like you suction them when you know that they need it. You suction them when you're not sure if, you know, if their cough is related to secretions. You suction to make sure that their inner cannula is patent or open. So, but just to be suctioning somebody every, you know, by a schedule, it shouldn't be something, you know, there should be like some indications, but you can't just go and say, well, I didn't hear him coughing, I didn't hear anything going wrong, so I didn't suction him for a whole day. I wouldn't do that either, but you know, it's an idea that you'll have training in what to look for, and then you'll have some things that you just do whenever like other things are coming up, when you're changing inner cannulas, things like that, that you'll have suctioning to be a component of it.
Okay, also, the process to put in a trach, when you have people with, you know, limited breathing capacity, is that a difficulty? Does it require a surgery where you have to go under an anesthetic?
Yeah, that's what you want. You want it to be a surgical procedure. That's what the idea behind elective tracheostomy. You don't want it to be emergent, because there are different kinds of like tracheotomies to where they do an insertion, and some of them are emergent, and that's not the kind that you're after. You're the kind that's very controlled environment in an operating room with several people around that control anesthesia, level of consciousness, control the airway. So you want to make sure that if you're going to have a tracheostomy, that's what you're doing, you know, that you're in there for a reason, and not because it's an emergent thing, which they can do in a lot of different kinds of ways. They can do that, you know, emergently. So you want it to be elective, and you want it to be a very controlled situation.
Okay. Thank you.
Yes, ma'am.
Are there any other questions?
I have a question. If a trach is placed, how long is a patient in the hospital, and how quickly are they able to transfer home?
Well, there's no set time, but generally it's like a week, you know,
Okay.
And maybe not that long, but I would like plan on being in for about a week, because the training starts when you're in the hospital after about the second or third day, where the nurses and the respiratory therapists that are on staff manage, you know, the new tracheostomy. Because remember, early complication of bleeding, you don't want to like have somebody practicing on you and trying to work it out, but by the third day or so, second or third day, and on to the end when you're discharged, that's when the family, the spouse, the caregivers, everybody is getting training. And then that training continues with like RQS and the respiratory therapist at home, where we meet you at the house with the ventilator and everything, you know, to get everything set up there. So it's not like, you know, there you go, see you later. You don't hop in a car. It'll be like a, you know, family in one ride, ambulance, people are at home, RQS respiratory is meeting you there, and everything is set up, and the training continues as soon as you get home too.
Right. Thank you.
You bet.
I have a question here from Raquel and Jennifer. Does someone with a trach need 24/7 care by their side?
By their side is great, you know, and that doesn't happen all the time. Somebody has to go to the bathroom, but yeah, it is 24/7. You can't be left at the house, you know, going shopping. It doesn't work that way. Somebody has to be in the house with you all the time. I can't say that's always the way it goes, but you don't want to be put in a spot where, you know, you're not without, you know, somebody there, because remember, ALS, you're not moving. And if you're not breathing unless you're connected to that ventilator, not good. Because I've seen it to where you could be on with a tracheostomy and on mechanical ventilation, cough real hard one time, that little connector wasn't put on the right way, and it's off. And there you go. You're done for unless somebody's there to like get it back on. So yeah, somebody has to be there. Absolutely.
I have a couple of comments in here as well. Diana says, excellent presentation. I really appreciate your information and compassionate manner.
30
Dutch
years
says,
healthcare.
there you go. And Wade also says, thank you. This is very good information.
Yeah.
I have a question.
Please.
About speaking. I don't know how much it affects, of course affects, but if you have any like percentage of people that can still speak after the
Oh yeah. You know, if you can speak before you have the tracheostomy in place, you can still speak after you have the tracheostomy. We're looking at like ventilation versus being able to speak. If that's the idea, you know, that's what you want to do, that if you can. It doesn't happen all the time that way. With ALS, sometimes speech goes away, but there are different types of tracheostomy tubes that can be in place if that's what your ability is. But if the respiratory system is weakened to the point where you needed to have mechanical ventilation, then no, generally you won't be speaking at all and not doing a lot of different things. But if somebody is in tracheostomy without ALS, and then you have this certain type of tracheostomy tube, you can have these little one-way valves that could be put in place here to where you can breathe in, and then with that with that certain type of trach and the cuff deflated, air moves past the trach tube through your vocal cords, and you can still speak. So with the tracheostomy tube, without ALS and that kind of respiratory muscle weakness that causes you to be on the ventilator, sometimes you could be on it to where you can talk. But if your respiratory muscles are weak enough to where you can't breathe without the device, then no, you can't talk at the same time, because you can't deflate that cuff or you won't be able to breathe. So the idea is that there are things out there, but it's not associated with ALS and those kind of problems.
Any other questions? All right. Well, thank you so much, Dr. Holt, for joining us today and giving us this presentation. We really appreciate it. For those of you who may have joined late, we will be sending out a recording of this afterwards, along with Dr. Holt's contact information. And we'll also be in touch with some of our future sessions. We're having a presentation next week, I believe, on your assisted technology options. So, you know, keep an eye on your emails, and our care services managers will be reaching out to you as well to let you know of ongoing virtual workshops, presentations, and of course our support groups, connection meetings, and caregiver groups as well. Thank you so much. I'm going to go ahead and stop the recording, and you guys enjoy